opposition of this person. This is what happens in the left heart. The arteries have a pressure that is important, a pressure that can make the blood, if there is a wound in an artery, spur with a stream very big. So high pressure. So the left heart needs to move the blood against this pressure. So this is a load. This is a work that opposes the work of the left heart, and it is called afterload. You need to understand that the pipes of the arteries are pipes, have a property. They can open and close because they have circular smooth muscle. It is called vasodilation and vasoconstriction. If the arteries are closed, the opposition is going to be bigger, is going to be higher. But if the arteries open, dilate, they are going to be more compliant, and the opposition to the emptying of the left heart is going to be decreased. So how we manipulate the afterload? We manipulate the afterload with vasodilators and vasoconstrictors. If we want to increase vasoconstriction, and increasing vasoconstriction, we increase, one, blood pressure, and second, we increase afterload, we use vasoconstriction, vasoconstrictors. Yes, a vasoconstrictor could be, for example, epinephrine, or could be dopamine, which is related with the epinephrine. Okay, but to decrease the afterload, to produce vasodilation and decrease the afterload, we use vasodilators. There are many vasodilators. Nitrates are vasodilators, very potent and rapid vasodilators. More steady and long-acting vasodilators could be the ACE inhibitors. Those are vasodilators. One of the consequences of the vasodilation is that the blood pressure will decrease. Depending on the blood pressure, depending on the amount of peripheral resistance or afterload, depending on the condition of the left heart, we anticipate doctors will order vasodilators or vasoconstrictors. If we have a patient that has low blood pressure, because the person has the blood vessel too open. For example, in anaphylaxis, what happens in anaphylaxis? The blood vessels are too open. And for that reason, the blood pressure is too low. You anticipate that epinephrine is going to be administered to return the vasoconstriction and normalize the afterload. If the patient has, by the contrary, very high blood pressure, and the afterload is damaging the left heart and so is producing failure of the left heart, then we anticipate that ACE inhibitors are going to be prescribed to open the arteries and facilitate the emptying of the heart. So they can ask you a question, what you anticipate is going to be ordered in a patient with heart failure, ACE inhibitors or, epinephrine. So you need to understand that if the patient has failure of the heart to move the blood forward, it's better to dilate the arteries to eliminate this guy, So this way, the left heart can move the blood in this direction without the opposition of the vasoconstriction. Those are the part that I understand because I understand the anatomy and the physiology of the circulation. So the first class, the class that you had before concept one, before fundamentals, is the class that allows you to understand all this stuff. For example, there is a question in Nclex that I remember was very interesting. How you expect to be the cardiac output is the question in Nclex. How you expect to be the cardiac output in anemia? It's a question in Nclex that that is a proof that understanding the physiology of the circulation, you can deal with the question. What is cardiac output? Cardiac output is the amount in milliliters. Milliliters is the measurement of volume. When we talk about volume, is the amount of a liquid or a gas, something that cannot keep the form by itself, need to be contained, yes? So volume refers to liquids and gases and are measured basically in milliliters and liters, yes? And we are talking now about the blood, which is a liquid. So we are talking about the volume of blood that is pumped by the heart in 1 minute. So it's in 1 minute. So in 1 minute, the heart contracts several times. You know that the normal rate of contracting in 1 minute is from 60 to 100. And the average of a person at the rest is around 70 beats per minute. This is the range of usual of heart rate that a person has. Each time the heart contracts, is going to speed, is going to push, is going to move forward a volume of blood. This volume of blood is called stroke volume. And this volume is at rest in an adult an average of 70 milliliters. 70 milliliters. So each time your heart makes a lot of a systole, you are pushing around 70 milliliters of blood forward to your aorta. And if you do that 70 times per minute, if you multiply that, you are going to have around 5,000, so 4,900. Yeah. 7 times 7, 49, yes, to 0. Okay, so almost 5,000 milliliters of blood is pumped per minute. This is your normal cardiac output at rest. If you go to the gym, okay, or the elevator in the school is broken and you need to climb 8 floors, okay, to go to talk to with me, okay, then what you expect happens to your heart rate is going to increase. Suppose that you increase your heart rate to 100, yes, and assume that you keep the same stroke volume. It's going to increase also, but assume that. So what is the multiplication now? What is the value of the multiplication? 7,000. So do you notice how the cardiac output changes depending of your heart rate and the stimulation or the needs of your body? So the cardiac output is variable. And you need to know in which condition the cardiac output is increased, in which condition the cardiac output is decreased. Of course, if you have a left heart that is weak, then the heart cannot pump too much volume of blood. So this 70 milliliters, which is the normal, is going to be decreased. And now it's going to be 50. So a heart failure decreases the cardiac output. How you can compensate if the stroke volume, the amount of blood that is pumped, can be compensated, this decrease can be compensated, increasing the heart rate. If you increase the heart rate in heart failure, so suppose that you increase the heart rate to 100 at the rest. So at the rest, what is this? At the rest, you have now 100. Instead of 70, you have 100. So how much you have? 5,000. So it's not the same cardiac output. So what you expect to happen in a person with heart failure, you expect that the person with heart failure is going to have tachycardia. Why is going to have tachycardia? Because it needs to compensate. Compensate what? The decreased stroke volume, the decreased volume of blood that is pumped by the heart because the heart is sick, is weaker. And it is important. It's important in the assessment because it's something that you expect. So the purpose of increasing the heart rate is with the purpose of increasing the cardiac output. How is the heart rate in hyperthyroidism? When the person has Graves' disease, this condition that increases the T3 and T4 and have popping out eyes, tachycardia is typical of the hyperthyroidism. So if you have a question that asks you, how is the cardiac output in Graves' disease increased, the same, decreased, you need to know it's increased. Why? Because each time that the heart rate increases, the cardiac output will increase. By the contrary, if they ask you, how is the cardiac output in a patient with hypothyroidism, in which you expect bradycardia because the metabolic needs are decreased, then you are going to answer the cardiac output is decreased. What about the anemia? What is the problem of anemia? The problem of anemia is the hemoglobin. What is hemoglobin? Is a bus, is a train, is a transporter of oxygen. Oxygen from where? From the lungs to work to all the body, including the brain. What happens when you have less than normal hemoglobin? Less than normal hemoglobin, you have less capacity of transporting the oxygen that is in the lung toward the body, especially to which organ? The master, the brain. So when there is anemia, brain start receiving less oxygen than needed, than normal. Why? Because the transporter is decreased. And brain becomes upset. And brain is the master. And what is going to do brain when is upset is going to activate the fight or flight system, the sympathetic nervous system. With which purpose? To increase the heart rate and increase the cardiac output. So now you expect that in anemia, tachycardia, no bradycardia, and you expect increase of the cardiac output, because if you have increased heart rate, you have increased cardiac output. You have increased cardiac output, no decreased cardiac output. The majority of my students, when I put this question, because when I talk concept 2 about anemia, and if they didn't pay attention to the explanation, because I explained that in class, they say that in anemia, because you are tired, you are weak, the cardiac output is decreased. Wrong, is increased, because compensation. I don't deny that in anemia, because you have less oxygen and less capacity of producing ATP, which is energy, you have tiredness, you have, decreased energy. But to compensate, you increase heart rate and increase the cardiac output. This is the way that Nclex tests cardiovascular. They explore if you understand the basic of the function of the heart. In reality, the questions of cardiovascular in Nclex are very specific to the most common diseases, ischemic heart disease, and to electrocardiograms, dysrhythmias, and this kind of anomalies, okay, related with the normal function of the heart. In Nclex, remember that you as an RN are going to evaluate it to a privilege that only an RN has, which is the privilege of assessment. So pay attention in each system when you study the part of med search, to dedicate at the beginning a little review to anatomy and physiology, as I just did, and a little review to assessment. This is a brief component that you have for my associate programs in fundamentals. I think that in the bachelor's is a little more extensive, but yes, you are going to be tested about techniques and interpretation of assessment, because assessment is a privilege given by the license to which you are applying. And I see many questions in Nclex about cardiovascular assessment. The majority are very basic. I'm pretty sure that you know perfectly what is the pedal pulse, what is the posterior pedal pulse, what is the radial pulse. I think that those basic, you have that. But there are some details I just wanted to review because are not so well known. One of these is the apical radial pulse deficit. I don't know if you have this concept clear, but I want you to understand that each time the heart contracts and makes lop is a heartbeat that can be heard with an stethoscope. You see this gentleman with an stethoscope placed in the chest and is listening the heart. So each time the heart makes lop, the gentleman is saying, "Oh, there is one beat." Yeah. And the lady has placing her fingers in the radial artery and a superficial artery that we have here in the wrist. And each time the heart contracts, sends a wave of blood and pressure along all the arteries of the body. And in the superficial arteries, we can palpate this wave. And this is the radial pulse. The pulse, that heart rate that is counted here in the chest, and specifically in the fifth intercostal space with mid-clavicular line, is called apical pulse. And the pulse that we count here in the counting the jumps or the pushes or thought that makes the radial artery is called radial pulse. Theoretically, in a person that has a normal rhythm and a normal heart, each time the heart makes locked up, mm-mm, you should feel one beat here, locked up, one here, locked up, two here, locked up, three here. You understand? So theoretically, a person counting the beats of the heart, suppose that has 70 beats counted, should be palpated exactly or very near, okay, the same amount of beats in the radial artery. This is the normal. No difference between the apical pulse, which is auscultated, and the radial pulse, which is palpated. This is the normal. This is the theory of, sorry, the normal. What happens when the heart has a dysrhythmia or arrhythmia? Yeah, better say dysrhythmia. But okay, suppose an atrial fibrillation that you know well. Because the irregularity of the heart, some beats are so weak, so abnormal that are unable to send a significant amount of blood and pressure until the distal artery, the radial artery, and the lady will not feel any pulse in one and some of the beats of the heart. But those beats that are inefficient to send blood to the radial artery could be heard by the gentleman. So the heart is going to do lop dop, but there is not going to be beat here in the radial artery. So now will appear a apical radial deficit. The gentleman is going to count, suppose 90 times lop dop, and the lady is going to count only 70 times, okay, pulses in the radial artery. So there is a difference, 90 here, 70 here, and this is arterial, it is, sorry, apical radial pulse deficit. Require two persons, one auscultating the apical pulse, other palpating the radial pulse at the same time, in the same 60 minutes, in the same time, counting that. It is accepted that a difference of 15 is significant. It suggests that the client is in dysrhythmia. The most common dysrhythmia is atrial fibrillation. And what should be done if an apical radial pulse is detected independently by two nurses? There is an indication to request an EKG, an electrocardiogram, for a detailed assessment of the cardiac rhythm and the placement of a monitorization in the client because it's in cardiac dysrhythmia. Those are the implications of this apical radial pulse deficit that have been tested and the application for nursing. Other question that I've seen that have been tested for some students in Nclex, that they ask them to calculate the pulse pressure. Pulse pressure is the easiest, okay, because it's the subtraction, systolic minus diastolic. The difference between the systolic and the diastolic is called pulse pressure. And that's it. This is just a calculation. So how is tested? Very simple. They say the patient has 130/80. How much is the pulse pressure? They say A 40, B 30, C 50, and C 70. And then you make the subtraction, you find the right number, and you click the right answer. That's it. Very simple question. No problem with that. Okay. In relation with assessment, I see very frequently, they ask you what happens if you want to palpate or auscultate the heart and it's difficult to do. You turn the client in left lateral. When the client is turned in left lateral, the heart displays and approximates the chest wall. And then the auscultation and the palpation becomes much, much, much easier. You need to know that there is one area in the chest that is very important. Is very important to know how to palpate. Sorry, and when you see me here is because I'm dealing with the marker to draw. This is the point of maximal impulse, or PMI. The heart has a pyramid shape. Heart has a pyramid shape, but the apex of this pyramid, okay, of this pyramid, this pyramid that is the heart, the apex of this pyramid is an inverted pyramid. No, the apex of this pyramid is against the left side of the chest wall, and this apex in adult has a very constant placement, which is the five intercostal space. Okay, intercostal space. So you count 1, 2, 3, 4, 5 spaces between the ribs. The first space that you count is the 2, because the first cannot be counted, is under the clavicle. 2, 3, 4, 5. Yes, and then you see the clavicle. Let me erase. You see the clavicle. Okay, this clavicle. Okay, come from here to here, and then you calculate what is the middle, and then you draw a line, a vertical line. Okay, downward, and when there is the intersection of the fifth intercostal space with this mid clavicular line, is where should be in a normal sized heart of an adult the apex of the heart. If this apex is displaced generally toward downward and toward the axilla, to the armpits, okay, is displaced of this position from the fifth intercostal space with big clavicular line, is because the heart is enlarged. Heart that are enlarged are called cardiomegaly, and cardiomegaly always translate a disease in the heart. That's why it's so important to palpate the point of maximal impulse, because it gives you an idea of the size of the heart. Every rule has exceptions that confirm the rule. For example, if you have a child, the position is a little higher in the fourth intercostal space. If you have a pregnant woman with a pregnancy at term, with an uterus, okay, a womb that is pushing the heart upward, the apex could be the fourth intercostal space. And if you have a guy like this, okay, a guy like this, and you're trying to find, okay, the PMI, is practically impossible. This place where the PMI is the same place where we auscultate the mitral valve. Mitral valve is the valve that is between the left atrium and the left ventricle, and it's a very important valve that is damaged frequently, okay, and can produce murmurs. So we auscultate murmurs related with the mitral valve because are more intense in this area. The same fifth intercostal space with mid clavicular line. Another valve that is very important is the aortic valve. The aortic valve is auscultated in the base. You remember that I told you that the heart is like a pyramid, is an inverted pyramid? Yes. The base of the pyramid, this is the apex, this is the base. The base of the pyramid is where the big arteries, exit the heart. The aorta is in the second intercostal space in this position, but at the right. Remember that the right is the client's right, is the screen right. Don't get confused in the test. It's not your right, it's the client's right. It's the screen right. This is right and this is left. Yeah, it's inverted. Okay, and at the right of the sternum. Those are the two most important places of the valve that you need to know very well. The other valves are the pulmonic or pulmonary and the tricuspid. The pulmonary is at the same level in the second intercostal space of the aorta at the left, and the tricuspid is between the fourth and fifth. It's an extensive area, fourth and fifth intercostal space, but at the left side, at the side of the sternum. Rarely tested. There is an herb point here. There is an accessory point to auscultate the aorta. It is not in the English. It's not Palenque. This is not in English. It is for the cardiologist to auscultate murmurs of aortic insufficiency. It is too much for entry-level generalist nursing. When we study right and left heart failure, we need to return again to the representation of the anatomy and physiology of the circulation. So if you have a question that say, which one are the signs and symptoms of right heart failure, you are going to say there is a failure of the pump. The pump is moving the blood in the direction of the arrows. And what I anticipate, if the blood is not moving in this direction in the lower extremities, I anticipate edema. So edema in the lower extremities is a manifestation of right heart failure. But take care with the edema. Edema is not dependable because it's a person with right heart failure, it's a person that is sick, has been spending all day sitting because it's not tolerating exercise, is sick, okay? And is sitting all day, you anticipate that the extremities are going to be swollen. But what happens at night? This person at night goes to bed, goes to bed. Beds usually are horizontal. And because the legs are swollen, frequently the on client or the CNA or the nurse are going to elevate the extremities, the swollen extremities, with pillows, okay, with pillows. So what you expect happens based in the action of the gravity force with this liquid that is in the leg that is going to be moving because the elevation of the legs is going to be moving in this direction. So now the liquid can accumulate in the back of the client, and even the liquid can be reabsorbed. And when it's reabsorbed, it's going to be here, is going to be in the lungs and could produce a transient overload of liquid in the lungs, okay, at night. So at night, the patient can wake up suddenly with shortness of breath because the liquid that was in the leg, not affecting the lungs, now moved at night when the legs were elevated, is moving to the lungs. So now the liquid is not in the legs, is in the lungs. So that's why the patient at night could have a shortness of breath and is going to suddenly wakes up with shortness of breath. When something occurs sudden, it's called paroxysmal. Paroxystic or paroxysmal means sudden, okay, in short period of time. And nocturnal means night. And dyspnea means shortness of breath. So it is called this dyspnea that can wakes up a person at night, okay, when the liquid of the lower extremities are reabsorbed, is called paroxystic or paroxysmal nocturnal dyspnea. So understanding the meaning of the words, we can know what the question is about without the need of memorizing so much. So trying to learn the meaning of the words. Paroxysmal, sudden, nocturnal, night, dyspnea. So a shortness of breath that appears suddenly at night when the liquid of the legs move from the legs to the lung. Why? Because the person went to bed and elevated the leg. Okay, this is what I had is called flight of ideas. Have you heard that in mental health? Flight of ideas. When you are thinking so fast that then you say when the you mix one phrase with the next phrase. Okay, this is flight of idea. Okay, take care with me. I have tendency to have flight of ideas perfectly. So now you understand how edema behaves in right heart failure. And that's why we call this dependent edema. What means dependent? Dependent is the part of the body that is in lowest position. If you are sitting, the dependent part is the lower extremities. But if you are resting with elevation of the legs, it's not more your lower extremities, it's your back. So you can have a question where you explore for fluid edema, fluid retention edema in a client that is bed bound. You are not going to explore in the legs, you explore in the sacral area. Yeah. And that's it. So if edema is not dependable, is something that can be confusing, which can replace the exploration of the edema, which is better, the weight. The weight, liquids weight. and the weight of 1 liter. 1 liter is 1,000 milliliter. Yes, the weight of 1 liter of liquid. Okay, 1 liter is more or less a quart for the Anglo people. Okay, is going to be equal to 1 kilograms. 1 kilo is 2.2 pounds. 2.2 pounds. Yes. So each time a person is increasing from one day to the next 1 kilo, John is increasing 1 liter, is retaining 1 liter of liquid. So if today I weigh 100 kilos and tomorrow I weigh 102 kilos, this change of weight in 24, 48 hours, so acute in so short of time, is liquid. So what means I retain two, because the difference is 2 kilos, or 2 liters, because it's the same, yeah, of liquid. And this is much better, because I don't care if the liquid is in the leg, or if the liquid is in the sacral area, or is in whatever part of my body. The weight is going to be much better. The changes of weight is going to be much better than the presence of edema, to determine if the client is retaining or losing fluid. So how is tested in Nclex? How was I saw this question in Nclex? The person is receiving furosemide for the treatment of heart failure, of fluid volume excess. How the nurse determines objectively, what is the best way of determining objectively that the medication is working, is doing what is desired. And you had two answers. The edema in the lower extremities decreased from 4 plus to 1 plus, and the other was the patient lost, okay, 2 kilos, or 4 pounds of weight from one day to the next. So which one is better? The weight. And you are going to choose weight. You are not going to be distracted by the edema. Why? Because edema is not dependable. The edema can move from the leg to other parts of the body and could misguide you. The patient is improving and is not. It's just changing of position. Uh, Understand the abdomen also can have edema, because abdomen also has, okay, a veins. And one of the organs that have more edema in the abdomen is the liver. So you have an enlargement, an increase in the size of the liver. It's called hepatomegaly. And because retention of liquid, retention of blood is called congestive hepatomegaly. This hepatomegaly is painful, because this distension of the liver produces pain. And this distension is very funny, because now the liver is bigger and is full of blood inside. But liver is like a sponge. You can push with your hands in the abdomen, you can push the liver, and you see how the blood is going to be a squeeze, because you are pushing, you are squeezing the liver with your pressure. The blood is going to be squeezed and move from the liver, and is going to enter the vein. And then you are going to notice, because those veins are communicated, you notice that the neck vein distension, the jugular vein, the veins in the neck of the clients, becomes more engorged, more distended than before when you push the liver. It is called hepato, because liver is hepato, jugular, because these veins are called jugular veins. Hepatojugular reflux is a manifestation of liver congestion. When the liver is enlarged, produces can produce ascites, or spill of liquid in the abdomen, can produce bloating, and can produce anorexia, because here is the stomach, at the left side of the liver is the stomach, and the stomach is compressed by the liver, and as a consequence, the anorexia can be present. The other manifestation of this right heart failure is in the veins of the neck. Okay, the neck vein distension is obviously an important manifestation. The only thing that I can tell you that could be tested about this neck vein distension is that in Nclex they ask you in which position you place the client to assess for neck vein distension. Has been accepted, standardized, that 45 degrees elevation of the head. So the client is going to be on bed, and you elevate the head of the bed 45 degrees, 45 degrees, okay? 45 degrees, okay? It's a mild Fowler elevation. And then when the client is in this position, you go to the neck and you evaluate for neck pain distension. Very simple. You don't need to go in depth of using a ruler, etc. No, no. Very simple. It's the way of evaluating that. It's a question of assessment. There is another detail that occurs when a person has right heart failure. When the person has predominantly right heart failure and the left heart is okay, as I said before, the legs usually are swollen because there is retention of liquid in the legs, okay? And at night, as we said, the legs are elevated and the liquid is reabsorbed. Some of this liquid that is reabsorbed is going to move, okay, to the right heart, is going to be reabsorbed in the circulation, go to the right heart, go to the lungs, can produce problems in the lungs, and can reach the left heart. Left heart is going to pump. Suppose that the left heart is working, is not affected, is going to be pumping this liquid to where? To the organs that are almost immediately at the exit of the heart, that are the kidneys. Kidneys, renal arteries are direct branches of the aorta. So now this liquid during the night, at night, when you are sleeping, at night, think about this, when you are sleeping, the liquid that was stagnant, okay, pulled in the legs, is moving to the kidneys at night. And of course, now the kidneys are receiving more liquid than usual. So what is the consequence of receiving more liquid at night in the kidneys? That you start peeing a lot at night, which is uncomfortable because it's going to wake you up and is going to produce a condition called nocturia. What is nocturia? Nocturnal urea. Nocturnal is night, and urea is peeing, is urine, no? Nocturia. Okay, nocturia is when you are peeing more than normal, more than usual during the night. So nocturia, because the reabsorption of the liquid that is pulled in the lower extremities during the night in right heart failure is a manifestation of right heart failure. By the contrary, when the problem is in the left heart, the function of the left heart is to move the blood basically from the lungs to the heart and from the heart to the rest of the body. So what happens now that the left heart is failing? The blood is going to pull. The traffic jam is going to be worse in the lungs. So now we have an issue. We have too much blood in the lungs. And you know that blood has a lot of water, a lot of liquid. So now we are going to have water, liquid spilled in the flesh of the lungs. In the flesh of the lung, we have one structure called alveoli, are like balloons connected with pipes that are the bronchioles and bronchi, and those balloons should be filled with air, not with liquid. Now, because we have too much blood, too much liquid, you are going to have an spillage of liquid in the alveoli. So now the alveoli are going to have some liquid spilled there, also in the interstitial space. And what is the consequence of this? Well, the consequence is that the gas exchange is going to be impaired. Why? Because we need to breathe air, no water. We are not fishes. So we cannot obtain oxygen from the water. There is no oxygen in this water. And the air is going to be separated from the hemoglobin by this layer of liquid. So now it is going to appear a impairment of the gas exchange. The amount of oxygen will drop. The amount of oxygen will drop, and the brain will detect this drop in the amount of oxygen immediately, and the brain will become very upset. So you are going to experience this despair, this anguish by the brain when the level of oxygen is low, which is probably the number one need of human, and the person is going to have dyspnea. So it's going to have the conscious sensation that is a short of air. And as a consequence, you are going to have two phenomena. Phenomenon number one is the activation of sympathetic nervous system, the fight or flight. So you're going to have tachycardia and all the activation of the sympathetic nervous system, vasoconstriction, tachycardia, etc. And you are going to have increment of the respiratory rate. It's interesting that this liquid in the lungs, okay, is a spill all over the lungs if the patient is in dependent position. If the patient is lying down, all the lung is going to be flooded by the liquid. But if the person sits, what happens with the liquid? The liquid is going to move to the bases of the lungs, leaving a part, the upper part of the lungs, free of liquids. So it is going to improve the client. So what position do you expect the client to adopt? The upright position. Which nursing intervention is a priority in this situation? If the patient cannot sit by him or herself, is elevate the head of the bed. This is the priority. If they ask you what is a priority, what you do first, elevate the head of the bed or you put oxygen? Elevate the head of the bed. What are you doing? Giving oxygen to a lung that is totally flooded. Nothing is going to be an oxygenated flood. Okay, but what you do first, you sit the client, the liquid goes down, you free some part of the lung from the liquid, and then you give oxygen. So first, elevate the head of the bed. Second, give the oxygen. This is the rationale for that. There is no reason for discuss these elements. This is a rapid intervention that is independent and need to be, and of course, frequently tested. What consequence are part of the, what other implication has orthopnea that I've seen in Nclex? A patient that has orthopnea doesn't tolerate the flat position, obviously. Well, there are some nursing interventions that usually are done with the client